guys. Okay, this week is week 8. This is going to be going over basic dysrhythmias. What I am going to do is I will provide the whole lecture on audio for you so you can listen to it. And then when we come in class, I am going to go over the part where you learn how to read each rhythm strip and then what the rhythms mean again, to kind of re-emphasize this, because it is difficult for some, especially in the beginning, because it's just so much content. So what do you need to know? These are the different things that we're going to go over today, and then again we will go over it in class. A basic understanding of the conduction system, identify placement of the ECG electrodes, understand the parts of an ECG waveform, comprehend basic steps for rhythm interpretation. We're going to analyze ECG rhythm strips to identify normal sinus rhythm, sinus brady, sinus tach, first and third degree blocks, V-tach and V-fib, and understand what may cause each of the dysrhythmias and nursing interventions. So cardiac electrophysiology. There are two parts that you need to have a properly beating heart. You need to have the electric cells, which is your conductive system, and these are specialized cells within the heart that can discharge an electrical current. This will initiate your beat. This property is called automaticity, and it initiates electrical activity and conducts it through the heart. So this is telling your heart that it has to beat, and it is done by these conductive cells. Then you have the actual mechanical cells, which is the contracting. So the actual beating of the heart responds to electrical stimulation, and it contracts to pump blood. The mechanical beating or contraction of the heart is what this part is. So a person will have both a heart rate and a blood pressure for this to work. The two components must occur for a heart to be able to contract and pump blood. So you need the electric cells and the mechanical cells. So it's the conductive system and a contracting system. Okay, moving on to cellular depolarization. This is the interior cell will become positively charged and the cardiac cell will contract. Okay, due to the movement of the sodium potassium across the cell membrane, this is when your potassium is on the outside and sodium is on the inside. So that's cellular depolarization. Again, this will have the cell contract. Cellular repolarization is when it rests. It is the resting cell, it repolarizes, then the potassium and sodium will return to where it was initially. So the potassium is mostly on the inside, while the sodium is mostly on the outside. And so you get this type of passing of the cells between each depolarization and repolarization, or contraction and resting, contraction and resting. And you know, an average heartbeat's what, 60 to 100 times a minute. So this is doing this every single beat in your heart. The conduction system is a specialized electrical cells in the heart, and they are arranged in a system of pathways called the conduction system. These specialized electrical cells and structures guide the wave of the myocardial depolarization. Remember, myocardial is your heart. The physical layout of the conduction system includes, we've got your sinoatrial node. You'll also hear it referred to as the SA node. Your atrioventricular node, which is the AV node. Bundle of His. It's also called the AV junction. Then you have right and left bundle branches and the Purkinje fibers. Okay, and this is going to be how this conduction system travels through your heart. And what I'm going to do is go through each of these sections next. Okay, so here is just a visual, so you can kind of see it. When you first start with your conduction system, you start up in the sinus node, or the SA node, and then it travels down to your AV node. It goes through the bundle of His, then it'll split off in your right and left bundle branches, and then it goes down to the very posterior part of your heart, or your the Purkinje fibers, and then that will create the contraction and relaxation of your heart. Okay, so this is your sinoatrial node, or SA node, or you even hear a sinus node as it referred to. This is located in the posterior wall of the right atrium. So if you look up at this figure here, your atriums are the top chambers of your heart, your ventricles are the bottom chamber. So this is your right top chamber. This is known as the primary pacemaker of the heart. The greatest automaticity is located in the SA node that normally fires at a rate of 60 to 100 beats per minute. So for you and I, hopefully we all have healthy hearts. Our SA node is what is going to initiate the conduction, and that way our heart should be beating at a nice healthy 60 to 100 beats per minute and having no irregularities. There is an atrial kick that occurs when the atrias contract, and then that is responsible for about 30% of the cardiac output. And this is important toward maintaining our blood pressure. We need a good atrial kick to start pushing our blood through the ventricles and to get it throughout the rest of our body. Your atrioventricular node, which you can see there, is located up in the lower right atrium. It's above the base of the tricuspid valve. This delays and relays impulses to the ventricles. Okay, so this is kind of telling you when it's telling the heart when the blood is going to progress into those ventricles. Okay, the bundle of His and right and left bundle branches, also referred to as the AV junction, is located in the upper portion of the interventricular septum. And these pacemaker cells are capable of discharging at an intrinsic rate of 40 to 60 beats per minute. This is a backup pacemaker function. So for some reason, the SA node is not firing correctly. As the blood is being ejected through the heart, hopefully the pacemaker cells in the bundle of His will start beating, and that will give you an intrinsic rate of 40 to 60 beats per minute. So this still is not, an ideal situation, but obviously it's better than your heart not beating at all. And some patients may be actually a little asymptomatic, because if they're 40 to 60 beats per minute, I'm sure you've seen people that have had their heart rates in the high 50s, and they're asymptomatic at that. Then moving down from the bundle His and right and left bundle branches, you have your Purkinje fibers, and these are the terminal ends of the bundle branches. So if you look up on the slide here, you can see how the bundle of His splits off into the right and left bundle branches, and then it goes down through the Purkinje fibers. The Purkinje fibers are the third and final pacemaker site. These pace at a rate of 20 to 40 beats per minute. Okay, so this is like our third backup for our heart to help contract and get blood throughout the system. But what do you think if somebody's beating at a rate of 20 to 40 beats per minute? You probably are going to see somebody that is symptomatic. And we're going to go through this a little bit more further in the lecture. Here is just a summary of the pacemaker functions. So if you want, you guys can print this out and look at this. But again, you've got your level 1, which is your normal one. It's the SA node beating at 60 to 100 beats per minute. Level 2 is your backup system. This is your bundle of His, the AV node and junction, and this is 40 to 60 beats per minute. And then level 3 is the lowest backup system. This is the Purkinje fibers within the ventricles, and this is 20 to 40 beats per minute. Okay, this here is an electrocardiogram. It's ECG tracing, or lots of people refer to it as EKG tracing. They just mean the same thing. So this ECG tracing is designed to give a graphic display of the electrical activity in the heart. The ECG cannot tell you about the mechanical activity of the heart. To assess the mechanical activity of a heart, you must assess the patient's blood pressure and pulse. So monitoring systems typically have a 3 or 5 lead system. We actually got a 6 lead system in the ED now, which is newer for us, but they are color coded cables. The negative lead is usually white, the positive lead is red, and the ground lead is black, green, or brown. And what do these leads do? They record the electrical activity between 2 electrodes. So each lead has a positive and a negative electrode on it. And the placement of the electrodes allows you to see a single view of the electrical pattern of the heart. Okay, these electrodes have adhesive pads that contain a conductive gel and are attached to the client's skin. So a good ECG signal requires good skin contact of those electrodes adequate conductive jelly in the center of the electrode. And you have to keep that in mind, that if you have somebody that has a lot of hair on their chest, or if they're dirty, you may have to actually clean the skin and clip the hair on the anterior chest to get a good adhesive going with that electrode. So if you guys have not had a chance to see what the electrodes are, they're down on the bottom right picture here. Most of the time they're round like that, and they either have a snap to snap in the leads, or they clip on. And then if you pull back the adhesive backing to it, the middle of it has like this gel on it. And that is the part, the conductive gel, that attaches, or that is contact to your client's skin and gives a good reading of that side of the heart. So common leads, lead 2, the positive is red and it's below the left pectoral muscle, and the negative is white below the right clavicle. It is the recommended lead for electrical cardioversion. Due to the large upright deflection, this will help when we try to cardiovert, and what we're really doing essentially is shocking an abnormal heart rhythm back into a normal rhythm. Now, we don't do this with every abnormal. I'll talk about this a little bit further. Popular phrase for lead 2 is smoke over fire. So if you look at this picture here, smoke is your black. Okay, so smoke is always over fire, right? You light a fire. So your red is down on your left lower, your black is up on your left upper, and then white on right is on your right side. So that is essentially how you would set up a 3-lead ECG on one of your clients. Okay, so the EKG or ECG paper, it's graph paper that is made up of small and larger heavy lined squares. The 5 small squares between the heavier lines prints at a constant and standardized speed. Each small square represents 0.04 seconds. Okay, and that is something that you should commit to memory because this is a universal thing, and every single time you see one of those small squares, it's 0.04 seconds. Each larger square, if you look up here, represents 0.20 seconds. Okay, so you're going to have 5 small squares in each of those large squares. Standard practice is to print a strip of at least a 6-second duration, which is kind of like at the size up here that you'll see that's a 6-second strip. And to determine the rate, you will multiply how many QRS complexes are in a 6-second strip times 10. You know, this is just an estimate. And please don't get too concerned about this right now. We're going to do this in class so much that you should be doing this in your sleep. Just because if you haven't done this before, it can be a little confusing. But again, with the hands-on, I think you guys will be good. Okay, ECG waveforms. This is going to help you see what all of these squiggly lines mean when you're looking at a cardiac strip. The first thing that you want to identify is if there's a P wave. This is the electrical impulses originating from the SA node. The P wave is indicative of atrial depolarization. Okay, this is good. We want to see a P wave before every complex because since it is originating in the SA node, which is the primary pacemaker of the heart, we should be getting a good conduction going with that. So just remember the P wave is indicative of atrial depolarization. The PR interval extends from the beginning of the P wave, which is atrial depolarization, to the onset of the QRS complex, which is ventricular depolarization, which is traveling through the AV node. So this is measured from the beginning of the P wave to the Q wave. This should not exceed 0.20 seconds. Okay, so from your P to your Q, when you're measuring them with calipers, which I will provide for you to use in class, each of these should not exceed more than 0.20 seconds. Now you remember the 0.20 seconds is one of those large boxes. This is important in identification of different heart blocks. Your QRS complex is the ventricular depolarization. This is a large complex of 3 waves, the Q, the R, and the S wave, which you can see down in this diagram that I have here. The upper limit of normal duration is up to 0.12 seconds or 3 small squares. So to see a normal ventricular depolarization, you don't want to see it larger than 0.12 seconds or 3 small squares. Your ST segment begins at the end of the S complex and ends with the onset of the T wave, and this is the early part of repolarization of the ventricles. And then the T wave is the ventricular repolarization where it relaxes. So your P wave is your atrial contraction, your QRS is your ventricular contraction, and your T wave is your relaxation or repolarization. So interpretation of ECG rhythms. This is an analysis of the waveforms and interrelations of the P wave, the PR interval, and the QRS complex. The rate, rhythm, site of the dominant pacemaker, and configuration of the waveforms require repeated practice. So again, we are going to do this next week in class. So if you are just thinking like, oh my God, what the heck is she talking about? Don't despair. I think once we start doing the hands-on stuff, you will see that this is such, it has such a good regimen of each step, which I am going to give you, that you will learn how to interpret basic ECG rhythm strips. So here are your 6 basic steps for rhythm interpretation. Okay, so your rate. What you're going to do is calculate the heart rate or note the heart rate from the monitor. So remember, in a 6-second strip, you're going to be counting every QRS complex and multiplying it by 10 to just get an estimate. So if you see 6 QRS complexes in that 6-second strip, 6 times 10 will be 60 beats per minute. Regularity measures the regularity or rhythm of the R waves. So you are going to take your calipers, we're going to march them out and see if the rhythm is a regular, nice regular rhythm. Your P waves are upright in lead 2, and we're going to look, does each P wave look uniform in shape, and is there a P wave before every QRS complex? Then you're going to check your PR interval, which should be less than 0.20 seconds, and then you want to make sure that all intervals are the same, or do they change, the P to R intervals. Then your QRS, you're looking to be no greater than 0.12 seconds, and is there a QRS before every or after every P wave? Normal rhythm strips show one P wave preceding each QRS complex, indicating that all depolarization is initiated at the SA node. Your QRS complexes without a P wave indicate a different source of initiation of depolarization. So I hope you guys understand that. If you have your primary pacemaker node working, which is your SA node, you will see a P wave. If you see a QRS complex without a P wave, this indicates a different source of initiation of depolarization. So that is going to be moving down in the heart to get a different contraction. Okay, so first one is rate. So if you look at this slide here, you see that first one, you see the first P wave, and then you see your QRS, then you see your T, then you see another P, QRS, T. So if this here, if you see the 3 seconds up on top, you'll see these little lines that are pretty small on top, but they do stand up. So in between each one is a 3-second interval. So when you print out a 6-second strip, you should actually see 3 little lines on it, right? So you have 3 seconds and 3 seconds. But this is how you're looking at it. And remember, each large box is 0.20 seconds and each small box is 0.04 seconds. And that's how you determine the rate. Regular. Is it regular or irregular? If you look at these here, and again, we'll go through this in class, the top one is a regular rhythm. So if you took your calipers and you measured from the P wave, beginning of one P wave to the beginning of the next P wave, and then you march them out, you would see that each of these P, Q, R, S, T complexes are at a nice even rate and they are regular. The one below that is a regular irregularity. The first one is a normal PQRST complex, and then you'll actually see a PVC, which is a premature ventricular contraction, and we're going to go over that a little bit further. But you'll see one regular beat, then a PVC, one regular beat, then a PVC. But if you march them out, and you would see where the P waves would lie, they would still end up being regular, but because there's PVCs in there, it's called a regular irregularity. Then the next one, if you look down, is regular with an ectopic beat. So that's where you may just have an occasional PVC show up, but again, these complexes should march out when you're measuring them, and they should all be normal. And even with that ectopic beat in there, if you continue to march it out, it should still keep going along. So it is regular with an ectopic beat. Then you guys, if you look at the bottom one, you can see that it is irregular even without having to march them out. You can see there is some depolarization sooner and later, but you can tell that it doesn't have a nice marching stance with that. If you measured them out, you would do the first two, then the next two look the same, but then when you go to the next one, you can see now it's beating a little bit sooner. So just looking at that strip, I would hope you could see that is an irregular rate with the strip. Step 3 is your presence of the P waves. So you want to look before every QRS complex and see if there's a P wave. Okay, is it upright? Okay, here actually you can see some of these P waves are actually depressed. They're going down. Is it uniform in shape? So is there a P before every QRS, and do they look the same? And do they occur regularly? And you can see on this strip there is quite a lot going on here to where it has got one depressed P wave, then there's none, and then you see at the end it looks like a normal P wave on the last two. Okay, so PR interval, again, we're going to do this in class, but you'll measure from the beginning of the P wave to beginning of the QRS complex, and you're going to measure the width. And remember, the width should be 0.20 seconds or less for it to be normal. And then you're going to do that for each one to see if the intervals are the same or does sometimes they change. Okay, and just eyeballing the strip here, this looks like they are normal and they are at a regular interval. And the QRS complexes again should be less than 0.12. Does it occur regular? So you're going to look at your QRS and you're going to measure those with your calipers, and if it's 3 boxes or less, then that's what you want with these. And then you would march those out and make sure that they are all the same. This is a busy slide. You don't have to memorize like this slide, but it just kind of shows if there's P waves. To the left it says if there's none. You know, it's kind of like just a chart to help you kind of go through and interpret what's going on. If there's no P waves and there's no QRS, it's flatlined or asystolic. If there's no P waves and there is a QRS complex greater than 0.12, it could be a block, or they could be going into a ventricular dysrhythmia. And then if they have a normal P wave and the PR interval is greater than 0.20, it could be a heart block. So there's several things. Again, I put this in here just so you can see how much the P wave does affect the deciding factor of what this rhythm is, but don't spend too much time on this chart because some of this stuff you're going to be doing in 3rd semester also. I'm going to tell you exactly what you need to know, and you will know by the end of this lecture. Okay, normal sinus rhythm on your ECG rhythm. This again is the dominant pace or function from the SA node. This is somebody that's healthy. Hopefully it's all of us. This fires at a regular rate of 60 to 100 times per minute, and all of the conduction pathways are working normally. So this is a salient feature. You know, this should just automatically happen where you have a rate of 60 to 100 beats per minute. Sinus bradycardia. This is when the sinus node is firing regular at a rate less than 60 beats per minute. Possible causes can be an increased vagal tone, if somebody is vomiting, or carotid sinus massage, A big one that we see to where someone will go have a sinus bradycardia rhythm is when they're bearing down during a BM because they're doing that Valsalva maneuver, which is increasing that vagal tone. So that's something you should be aware of, especially since you're doing your clinical on the med-surg floor, that many times if we have somebody that's going to the bathroom and they're really straining to have a BM, they may actually become faint. They can be symptomatic from it, or you would see a decrease in their heart rate possibly. And again, that's that Valsalva maneuver. Other possible causes could be medication side effects, like digoxin, right? You guys were trained to check an apical pulse when you give digoxin, and you want to hold it if it is less than 60 beats per minute, because again, they could be causing it from that med. We could be very fit athletes. Many times their heart does not have to pump as hard to contract throughout the body. So really good athletes normally will have a lower heart rate normal for them. Collaborative care, so you want to observe for symptoms of bradycardia. So some symptoms that you may see is shortness of breath, fatigue, again, blackouts, they could have a syncopal episode, lightheadedness and confusion, if they're really bradycardic. So if they're symptomatic, you want to put oxygen on them, because remember, if their heart is not beating at a nice normal 60 to 100 beats per minute and they have some of these symptoms, they're going to be needing oxygen in their body because their blood is not perfusing through their body as fast as it should. We may give atropine to help increase the heart rate. And then if the atropine doesn't work on someone that is symptomatic sinus bradycardia, we will do transcutaneous pacing. Okay, and I will go over that in more detail for you guys. So this here is a strip for sinus bradycardia. Okay, so we're going to look at it. And first you want to check, is there a P wave before every QRS complex? Is the P wave less than 0.20? We would measure that out. Is the QRS at less than or equal to 0.12? Is there a T wave? And do they march out? So if this was a 6-second strip, you would count every one of those QRS complexes. So that's 1, 2, 3, 4, 5. Okay, 5 times 10 would be 50. Okay, so that is just an estimate, but it looks like on this strip, this person has sinus bradycardia at 50 beats per minute. Okay, sinus tachycardia. This is a rapid rate of discharge of the SA node. So this would be usually between 100 beats per minute and 160 beats per minute. Although it could still be a sinus tachycardia higher, but normally 100 to 160 beats per minute is what you would see for sinus tachycardia. Normal causes. There's a normal cardiac response to demands for increased oxygen needs during, like if they have pain, they may have sinus tachycardia. If they have a fever and they need increased oxygen demands, you'll see sinus tachycardia. If you're stressed, you could become tachycardic. And then if you are dehydrated, you don't have enough fluids pumping through your body, your heart's going to start pumping harder and faster to try to perfuse that. That could cause sinus tachycardia. And then exercise, right? That's the one that I think we all should be experiencing. As you exercise, your heart rate increases because you need greater oxygen demand, and that would be sinus tachycardia. Some other things that could cause sinus tachycardia include caffeine or nicotine ingestion, possible MI or early signs of heart failure. You may see sinus tachycardia. And then collaborative care. So if somebody is symptomatic with sinus tachycardia, they may complain of chest pain. This increases your myocardial workload and oxygen demand. So just keep that in mind. Somebody may be asymptomatic, but they are symptomatic. You may see someone complaining of chest pain because remember, your heart is beating harder and faster to increase that myocardial workload and oxygen demand. So how do we fix this? We want to treat the underlying cause. So if it's someone that's dehydrated, we're going to hydrate them. If they have anxiety, We're going to try to use nice breathing techniques and try to talk them down, and we may have to give them some medication to help with that. They may be given some drugs like beta blockers, right? Beta blockers do slow the conduction of the heart rate. So if we have someone in sinus tachycardia, they may be given something like a beta blocker. So here is a strip of sinus tachycardia. And how do we know it's sinus tachycardia? Well, first you want to make sure there's a P wave before every QRS complex. You would measure the P wave, make sure it is 0.20 or less. Then you would measure each QRS complex and make sure it is 0.12 or less. And then do they march out? Is it normal? Yep, they're in a sinus rhythm here. And then you would count those beats in that strip. So if this is a 6-second strip, you're looking at your QRS complexes. And I count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 times 10 is 120 beats per minute. Okay, atrioventricular blocks. We're going to go through these, and I'm going to explain the second degree also, but you do not need to know second degree for the exam. They are going to be going more in detail with that next semester. But the first degree AV block is the one that I'm going to be talking about. And this is a delay caused by the first degree AV block, which prolongs your PR interval. So this is where your PR interval, when you measure it, is greater than 0.20 seconds. The PR interval is consistently prolonged the same amount in every cycle, and the PQRST sequence is normal in every cycle too. Okay, if that's confusing, don't worry, we will go over it in class, but that's when you're measuring your P to the beginning of your Q wave, and if it's greater than 0.20 seconds, and you're going to march that out, and you see that they're all the same size. So let's say it's 6 small blocks, which would be what, 0.24 seconds? But if you see it's 0.24 seconds before every P to Q wave, then you would be in a first degree block. And again, this is just a delay caused by the AV block prolonging the PR interval. Okay, second degree blocks. Some impulses reach and others are blocked. So the PR interval varies with a second degree. Type 1 is also known as a wanky-bocky. And I have that up on the slide because that is a weird name. I'm assuming that is the gentleman or woman who discovered this type of block. This is a progressive lengthening of the PR interval until the final P wave is totally blocked in the AV node. Type 2 is Mobitz, and this is a block of the Purkinje fiber bundles. It blocks a number of paced atrial depolarizations, which is your P waves, before conduction is successful to the ventricles. And it may produce a 2-to-1, so 2 P waves to every 1 QRS, or 3-to-1, 3 P waves to every QRS or higher. With Mobitz, or your type 2, every cycle that's missing its QRS has a regular punctual P wave, never a premature P wave. And again, please, you'll go into more detail. I can show you in class, but that's not something you're going to need as far as the content of this course and this exam at this point. We're going to be going over the first degree, which I just told you about, and then third degree. Third degree AV block, none of the impulses reach the ventricles, so it completely blocks the conduction of the atrial stimuli to the ventricles. So there's going to be no rhyme or reason when you're looking at these, and I will show you strips that have these. Okay, so first degree AV block, it's a prolongation of the PR interval beyond 0.20 seconds. So if you look at this strip that I have up here, you can see each P wave, and there is a P wave before every QRS complex, but it is greater than 0.20 seconds. Remember, 0.20 seconds is one of those large boxes, and even without calipers to measure this, I would hope that you could see that that P wave is greater than 0.20 seconds. Then when you're measuring your P to Q PR interval, which is your P to the Q wave, and if you measure out each one, you'll see they are all the same. So there is no change with that. So that would be your first degree block. Third degree block, there is no conducted beats. This is a slow ventricular rhythm, usually under 45 beats per minute. There is not a P wave in front of every QRS. It prevents sinus-paced atrial depolarization from reaching the ventricles. So for second and third degree blocks, when a QRS complex is not preceded by a P wave, ventricular and atrial depolarization are initiated from different sites. Okay, so I don't know if you guys can visualize that in your head, but remember the P wave is your depolarization, QRS. P wave is your atrial depolarization, QRS is your ventricular depolarization. So if you don't have a P wave before every QRS, when there's not a P wave, there's no atrial depolarization. Okay, so they are going to be originating from different sites. Okay, so nursing interventions and care. If you see a heart block, you want to observe for lengthening of the PR intervals or development of a more serious heart block. You want to treat the cause. So if you see somebody that's having symptoms and they have a heart block, it could be from a drug toxicity. Sometimes it's from a drug like digoxin or beta blockers or calcium channel blockers. It could be an electrolyte imbalance, like it could be high potassium levels. If you see a third degree heart block, again, that is an emergency because at that point they are not getting the depolarization sufficiently through the atriums and the ventricles. So if you see someone with a first degree heart block, treatment is usually unnecessary. The heart rate's usually normal, and we're just going to observe that and just make sure it doesn't progress to a further block. A second degree heart block, if it's not symptomatic, we usually don't treat second degree also. But if they are symptomatic in a second degree, we'd give them some oxygen. If they're bradycardic, we may give them atropine. If the atropine doesn't work, if they're bradycardic, we may end up doing some transcutaneous pacing. Third degree heart block, you're doing the same as a second degree. So we give the oxygen. We may give atropine if they're bradycardic. We may do transcutaneous pacing. But you want to check their LOC if they have third degree heart block. They may have inadequate cerebral perfusion. So these clients may be altered, they may be unconscious. So it's always important if you see someone in a third degree heart block, you go check that client out and make sure that their level of consciousness is okay, because again, they could have inadequate cerebral perfusion. Okay, so here we go on with ventricular dysrhythmias. Okay, ventricular dysrhythmias originate in the ventricles. The QRS complex is greater than 0.12 seconds, and they can be very dangerous. What happens is they trigger our VTAC and VFib. If in a ventricular dysrhythmia, we lose our atrial kick because we're not using the atriums, and the heart's efficiency is greatly reduced because now we just have got ventricles contracting. Okay, premature ventricular contractions, or PVCs. This is ectopic. Ectopic just means abnormal. So it's an ectopic beat originating from an irritable cluster of cells in the right or left ventricle. Before the next expected sinus beat, you have a premature QRS complex. The QRS is usually wide and bizarre looking. So if you look down at this small strip that I have on here, you see your P wave, you see your QRS, and then a T wave. And then you see this premature, wide and bizarre QRS. And then it looks like there's maybe like a pause, and then it goes P, QRS, T, it goes back into the rhythm. That is a premature ventricular contraction. Okay, so premature ventricular contractions, there's different types and terms. We've got a unifocal PVC. This is a single focus in one area. The morphology or waveform will look the same. Many times somebody that smokes, you may see unifocal PVCs on their EKG. Multifocal PVCs, there's several ventricular foci. It's a greater irritability. There's different looking PVC waveforms, and these are more dangerous. So again, multifocal, you'll be seeing PVCs that look different because there's firing from different areas of the ventricle. that's causing these PVCs. Couplets are two PVCs together. Ventricular bigeminy is when every other beat exists, when a normal complex and premature complex occur, and they alternate in a repetitive two-beat pattern with a pause occurring after each premature complex, so the complex occurs in pairs. So you will see a PVC, then a QRS wave, then a PVC, then a QRS wave, PVC, QRS wave, and it'll be quite obvious when you are even just eyeballing a strip like that. Ventricular trigeminy is every third beat, you'll see a PVC. Ventricular quadrigeminy is every fourth beat. So here is a strip of premature ventricular contraction. This is a bizarre premature QRS. Can you guys see it if you look at it? It is 1, 2, 3, the fifth beat if you're looking at your QRS complexes. Okay, so the QRS in that PVC is wide and bizarre. You know, it's greater than 0.12 seconds. Remember, 0.12 seconds is just 3 of those small boxes, you know, so it's definitely larger than that. And a P wave may be lost. And in that one, yeah, we don't see a P wave before that PVC. Then it looks like there's a pause, and then you start again with your P, QRST complexes. So again, that is an example of a premature ventricular contraction. This would be a unifocal PVC because it's just one, you know, that we're looking at on this strip. Here is some pictures of your unifocal and multifocal PVCs. So if you see the top strip, you see a regular PQRS complex. Then you got your wide and bizarre, so there's a PVC there. And you see another PQRS complex, there's 3 of those. Then a wide and bizarre PVC. And then you'll see 4, and then a wide bizarre PVC. You know, so this is a multifocal PVC. It's not creating a pattern where it's like every second beat or third beat or fourth beat. You know, so we just say this has multifocal PVCs on a strip. If you look down on the second strip, if you're looking at your PQRS complexes, if you count over 1, 2, 3, 4, 5, 6, those fifth and sixth ones, those look like PVCs to me, and it goes back into your normal QRS complex. So that, you know, could be, you know, it's a multifocal PVC on that one too, where we've got 2 of them and they're back to back. So that type of PVC, you may actually, your client may tell you, know, I feel my heart skipping a beat or something because of the fact that it may not be contracting as effectively as it could. Then the bottom strip, you'll look, it looks like the end of a PVC at the very beginning if you're looking at the top lead, which is your lead 2, and that's what we're going to be primarily looking at. And you see your PQRS complex, you'll see 2 of those, your big wide bizarre PVC. Then it looks like there's a little pause, then your 2 PQRS complexes, then another wide bizarre one, and then 2 and 1. So the PVC is every third beat, right? 1, 2, 3 is your PVC, 1, 2, 3 PVC, 1, 2, 3 PVC. So that is trigeminy. Okay. Again, I'll bring these slides in class, and then I'll have some for you guys to look at and practice and try to interpret in class so I can help you out. Okay, so what causes these premature ventricular contractions? These are some examples of things that can cause PVCs. And then there's this little saying that if you commit to memory, it may help you. It's Hank and Harry have depressed, enlarged hearts. So the first one is hypoxemia can cause PVC, acidemia, hypokalemia or hypocalcemia. Drugs like digoxin could cause PVCs. Epinephrine. Epinephrine also includes stress, emotions, fever. And then hypomagnesemia. So those are just some examples that can cause PVCs. Other things that cause PVCs, caffeine, smoking, and alcohol. So here's are some examples. So if you have somebody that's having, saying they're having fluttering in their chest every once in a while, it may be because one of these things that so many people use on a regular basis. So collaborative care, what do we do if we have a client that has PVCs? Um, Really, collaborative care is really only required when PVCs are frequent or the client has intolerable symptoms. If they're asymptomatic and we're pulling a strip every once in a while to look at their heart rate, you want to rule out hypokalemia if you see PVCs, or hypoxemia. If they do have hypoxemia, what do? Right? You can put a little oxygen on them, and that can essentially help the heart relax to where it'll get the good conduction going again, and you can rid of those PVCs. If someone's symptomatic, like they're having an acute myocardial infarction, also known as a heart attack, the PVCs indicate a need to aggressively treat the ischemia or the infarction in the heart. Okay, and you're not going to learn how to see a heart attack on a strip on this one just because there's so much information, but it is a type of PVC that we see that tells us, okay, between looking at the strip and how the patient or client is presenting, which they're symptomatic, we would know that they're having a heart attack. But if they are having a heart attack, you want to make sure they're given some oxygen. We'll give nitroglycerin. They could receive morphine and some antiarrhythmic agents to help get that heart beating in a regular pattern again. They may, many times, have to go to the cardiac cath lab because they need to get that heart opened up to reperfuse again, because it could be an actual blockage that's causing that PVC. So if you have somebody that's being discharged, after they've had a heart attack or PVCs, where they're having symptoms, you want to educate your clients to stop smoking, stop doing illicit drugs, drink alcohol in moderation. I always like to decrease stress, right? Because who isn't stressed, but okay, sir, you just had a heart attack and we fixed you up, but now you need to go home and decrease your stress. Good luck on that. But we do need to try to teach them that, maybe teach them some relaxation techniques, or something to help them out. And you also want to educate regarding adverse effects on medications. Okay, because if there's a medication that potentially causes PVCs, they need to know that, so that way it can help us if they do know the side effects of the medications. They also need to keep a current medication reconciliation for future healthcare providers to review. So if you have somebody that you cared for and they're being discharged home and they're going to have a home health nurse come and check in on them and maybe do some treatments, it is important that you report off to the home health nurse what their medication reconciliation is, so that nurse knows what medications he or she is on, so that the nurse can look out for these side effects. So remember, I keep telling you this, an SBAR report off to whoever is next in line to care for the client is very important. And so that shouldn't even stop when you discharge them from the hospital if they're going to continue to get care at home. Okay, now we're moving on to ventricular tachycardia. Ventricular tachycardia, or VTAC, is defined as 3 or more consecutive PVCs in a row at a rate greater than 100 beats per minute. So, if you look at the strip, there is no P wave, right? There is no depolarization that is occurring into atriums. It is only the ventricles that's doing a depolarization, and this is not good if you see somebody in this rhythm. It has to be, usually it's greater than 100. So if you look at the strip here, see how many PVCs do you see in this? And I'm counting them. I got 1, 2, 3, 4, 5, 6, 7, 8, 19. So 19 times 10 is what? 190. So they're right now have VTAC about 190 beats per minute. Do you think you would be doing well if your heart isn't having good contractions in the atrium and it's beating at 190 beats per minute? I would hope you would think no. But features that you will see is the rate is usually between 100 to 250 beats per minute. The QRS is greater than 12 seconds. And the QRS looks bizarre in appearance. Okay, so this is kind of a salient feature here. This again is a run of VTAC. So collaborative care. If you see somebody that is in VTAC, what do you do first? Your ABCs. Airway, breathing, circulation. Airway, breathing, circulation. Circulation means you need to check for a pulse, okay? Because you may still have a pulse if you are in ventricular tachycardia, but you may not have a pulse, so you need to know. Remember, when you're looking at the monitor, that is showing your electrical conduction, but you need to be able to palpate a pulse to see if there is mechanical contraction going on. So look at your client. Don't just look at that monitor and go, oh my God, my client's in VTAC. Go look at them. It could be something to where something's not hooked up correctly, or there's something. So you always want to look at the client, so look at the machine, you see that, and the first thing you want to do is check their ABCs and make sure your client is okay. Check your leads, make sure the leads are on correctly. Is it a drug toxicity? If they have someone that has been on meth or cocaine, that can cause ventricular tachycardia. Is there an electrolyte imbalance? Get those labs drawn stat, because they could be like hyperkalemic or something to put them in VTAC. You want to put them on oxygen. You want to get IV access. And if they don't have a pulse, you would begin CPR. Okay. There is an ACLS protocol. You guys may choose to go and get certified in this once you graduate. Some departments require it, and so they will pay for it, if you're in an area that requires it. But ACLS means Advanced Cardiac Life Support. And what we need to do is, if they have a pulse, we would do a synchronized cardioversion. And if they don't have a pulse, we could do defibrillation, where they defibrillate them. And then there's medications that we may give in the ACLS protocol. So that just is in a nutshell. So remember, look at your patients, check their ABCs. With the ABCs, do they have a pulse? If they don't have a pulse, begin CPR, okay? Then we have ventricular fibrillation. There is no organized ventricular depolarization going on, okay? This is a medical emergency. So imagine shaking a bowl full of Jell-O, and just how it kind of shakes around like that. That's what the ventricles in the heart is doing, okay? There is no contractions going on. The blood's just kind of getting shook around in there, but there is no rhyme or reason for it. The client does not have a pulse, any cardiac output, or a blood pressure, okay? So this, again, is a medical emergency. So coarse VFib, I'm going to show you, there's coarse VFib. You may see some fibrillatory waves. That's coarse. So I'll show you a strip in a minute so that'll make more sense. Or you may see fine VFib, which is similar to asystole. There's less success with defibrillation, because if they're fine VFib, things are starting to settle down in that heart, which means the heart is dying, and if we don't get them back soon, they go into asystole. It's very hard to reverse someone out of that situation. Okay, so here's a couple strips of ventricular fibrillation. If you look at the top, that would be a fine VFib. There's not much going on there. There is no contraction going on. There's no depolarization or repolarization going on with that. Same with the bottom one, but that is your coarse VFib. You see, it's coarse. There's no rhyme or reason for that, but there is still some fibrillatory things going on in the heart. So it's still moving around more than it would be on that fine VFib on top. So it's a chaotic, wavy recording, and there's no discernible rhythm. Collaborative care that you're going to do for this. Your client's going to be apneic, pulseless, and unresponsive if they are in ventricular fibrillation. So jump on that chest and begin CPR. Start doing the contractions for them by doing chest compressions. We will begin the ACLS protocol. Again, Advanced Cardiac Life Support. One of the things that we do is we try to figure out, why is this client having VFib? So it could be an acid-base imbalance, an electrolyte imbalance. There's many different causes that can cause this. But if they're in VFib, you want to defib. Stick that in your brain. VFib, you defib. So ventricular fibrillation, you need to defibrillate, which means you need to shock that heart and try to shock it into beating again, because it's just sitting there like a bowl of jelly, just kind of shaking around in the ventricles. When you prepare to defibrillate anyone, You want to make sure everyone is clear of the client. Because if you are leaning up on that gurney and you defibrillate, guess what? That conduction is going to go through. It's going to shock you also. So when you VFib, you defib, you want to make sure everyone's clear. Okay, everyone has to step away. They have to stop doing chest compressions for a second and make sure you're not leaning on that gurney next to the client. And then you defibrillate, and then you go right back down on that chest and do compressions. There's medications we give. We give epinephrine. We may give vasopressin, amiodarone, or lidocaine. I'm not going to test you on the medications because, again, that's an ACLS protocol. But just know primarily, you know what ventricular fibrillation is, that you begin CPR and you're going to defibrillate. Okay, and our last one, we're almost done here, guys. This is asystole. This is a total absence of electrical activity. There is no ventricular contraction. You may hear someone say, oh yeah, they're flatlining. That's asystole. This will be indicated by a straight line that you will see on the ECG or EKG. And you look at the straight line, there is maybe some curves to it, but you can tell that's not even a fine VFib at this point. Okay, so that's asystole. So what do we do if we see a monitor that shows asystole? You're at the nurse's station. You know, what do? Oh my goodness, they're in asystole. First, you need to assess your client, not the monitor. Okay, there are many times where the leads may be knocked off, and they're sitting up watching TV and they're perfectly fine. And again, you're running into the room looking all crazy and they're like, are you okay? They're worried about you because of the way you look. You know, so assess your patient, not the monitor. They cannot be in asystole if they have a pulse. Okay, so you may switch to another lead and check the electrodes, you know, to make sure it is true asystole. If they are unconscious and you don't feel a pulse, you know, you check your ABCs, you initiate CPR. Again, jump on that chest. When I say jump, I mean just start compressions. You're not physically jumping because, you know, I can see you guys trying to imagine what I'm saying here. When we jump on the chest, we just start compressions right away. You don't even think about it. Someone just start those compressions. That's what we need. And call for help, okay, because we do need more help. Other collaborative care, we're going to do the CPR. They may get an airway, so they may intubate the client, and we need to have IV access. Since there is no electrical activity in the heart, we cannot shock them. Okay, there's no defibrillation if somebody's in asystole. You want to search for possible causes. So it may be an acid-base imbalance. It may be an electrolyte imbalance. There's this whole protocol, but that's ACLS. I'm not going to have you memorize that right now. So just remember, if you see asystole, make sure it's for real. Assess your client, assess their ABCs, start CPR immediately, call for help. And the only way that we can really reverse an asystolic client, and it's really hard, many times if they're in asystole, they are going to die. But every once in a while, we can assess some of the causes and reverse them through some sort of medication treatment. You know, and every once in a while we can get them out, but usually asystole is pretty bad. So that is it, guys. I know that's a ton of information. Hopefully you will listen to this before you see me next Wednesday. And then I'm going to go through the whole last half of this slide again. And again, we're going to practice strips. I'm going to show you all different strips so you can practice and look at and be able to identify these different types of dysrhythmias. So if you have any questions, as always, please let me know, but I will see you soon. You guys have a great day.